Merhabalar, hoş.
Hello everyone, welcome. Today I will be talking about psychiatric assessment and monitoring in bariatric surgery. Bariatric surgery is a new topic in Turkey and in the world over. And as psychiatrists, as professionals, we don't know where we stand, and there are so many things that need to be discussed in bariatric surgery. However, I know that my time is limited, so I'm going to be as fast as possible. If you have any questions, in the end, maybe we can discuss those questions. Obesity, increasing of fat tissue, fat cells, and we have the body mass index. And if it is more than 30, there's obesity. If it is more than 40, there's morbid obesity. And we know that it is the plague of the age. It is increasing the world over, especially in children, in adolescents. Compared to the adults, it is disseminating much faster. And we have body mass index is more than 35 and 40, quite a lot. And comorbidities are also on the rise because obesity prevalence is increasing, and this comorbidity is causing 2.5 million deaths a year in the world, and it also creates a shorter lifespan, expected lifespan, because of this. With obesity, you have so many medical comorbidities, hypertension, from hypertension to cancer. You have so many different diseases. So obesity is increasing so much. How about the treatment of obesity? What is being done? Weight loss pharmacologic treatments are available, as Alican mentioned. There are other conventional treatment methods like diet, exercise, acupuncture, but in the long run, the efficacy of these treatments are rather limited, and the patients are not really attracted to these methods. This is a study that was conducted with diet and activity. Bariatric surgery compares diet and activity and bariatric surgery. In the long run, in order to achieve weight loss and permanence, there's a marked difference. Why surgery? Bariatric surgery. This is a patient, bariatric surgery patient. Before picture, before the operation, and the second picture is 6 months after the operation. And these pictures are shared on social networking sites. And they are quite attractive for obese people. Sometimes the patients, without questioning the surgery, they just come and to lose weight. They just want a surgery because they see these pictures. And they are really so attractive. In the 90s, the number of surgeries was 5,000 in 2010. It shot up to 200,000. And in Turkey as well, of late, there's a significant increase of bariatric surgery. Baros means weight in ancient Greece, and it is also known as weight loss surgery or metabolism surgery. And the indication for surgery, the American Healthcare Institute in 1991, body mass index more than 40 or more than 35 were deemed suitable for surgery. For psychiatry, this is what we need to say. Access to psychiatry should be ensured, it says, but there's nothing about a psychiatric assessment for these patients. That is not a prerequisite. Different types of surgery, these are important as well. And based on these different methods, weight loss, different sorts of weight loss is achieved, and the complications that arise later on also change. There are 3 types. One is restrictive procedures that restrict food intake, and malabsorptive procedures, and mixed procedures. In Turkey, in the world over, laparoscopic gastric bypass is the most commonly used method, and then you have laparoscopic sleeve gastrectomy, and then you have the adjustable gastric band, which is rather like cuffs or handcuffs, and also there is no consensus on which obesity patient is suitable for which method, and post-op prognosis also differs on the type of the surgery. And it is also known that weight loss, types of weight loss is differentiated, and complications also differ based on the method used, and we need to be aware of these differences. So what are the targets of surgery? Well, not to make the person thin, but to get rid of more than 50% of the excessive weight, and also improvement in comorbidities, and also maintaining the weight loss.
Hedeflemekte.
And it's not a simple procedure. It has very important surgical complications. It starts from mortality to constipation. And a lot of complications may arise, and 20% of these patients cannot get the results they are expecting, or they regain most of the weight that they lose right after the operation. So what is the success criteria for surgery? Is it just the weight loss or the amount of weight that is lost? Can we say that this procedure is successful just because the patient lost a lot of weight? Actually, this is quite controversial, because psychosocial and psychiatric conditions can be a criteria in order to define the success of the surgical outcome, but this is still under discussion. But we know that quality of life and the psychological condition changes when they start losing weight, because some patients right after the operation are afraid of gaining weight after losing their weight. They have a lot of anxiety and they restrict their food intake quite considerably. But this surgery is irreversible, and it necessitates a lot of changes in lifestyle, and it requires a lot of adjustment. So these patients need to be selected on a psychiatric assessment basis before the surgery. And the bariatric surgical patients are a special bunch. Why? Because their psychiatric illness prevalence is much higher compared to obese patients who do not have psychiatric disorders. And there is a trial here, and we know that 66% of these patients have a lifelong axis 1 diagnosis, 38% have an axis 1 diagnosis, and the rest had axis 2 diagnosis. And the most common diagnoses are, anxiety disorders, mood disorders, binge eating, personality disorders, nocturnal binge eating, and they have a misperception of their body image, and they have a history of abuse in their childhood age, and they have some alcohol and substance abuse in 32.6% of the time. And we see that these patients, 1.7% of these patients still have alcohol and substance abuse disorder. So this can be cultural, but we don't have any trials conducted in Turkey. 16% of these patients are also assessed by a psychiatrist, and 41% are using psychiatric drugs. And most of these drugs are antidepressants, anxiolytics, and antipsychotics. This is important because sometimes the secretion changes post-op, so the metabolism and the secretion and the digestion of these drugs will change post-op. So what are the consequences of psychiatric disorders on these surgical outcomes? We don't know the answer to this question because there are no standardized protocols pre-op, and it's really difficult to make a comparison. When we look at the trials, we cannot compare them, among themselves, and after these surgical operations we don't have longitudinal follow-up studies, so we cannot say anything for sure. But when we look at the trials, we see that pre-op, rather than the existence of the psychiatric disorder, the severity of the disease is a better predictor for the surgical outcome. If the patient has a psychiatric disorder which necessitated hospitalization, and if they had multiple episodes, then their psychiatric condition is more negative and the surgical outcomes are not that good. And lifelong anxiety and mood disorders cause less weight loss after the operation. And when we look at these patients, especially for binge eating patients, the medical complications, we see more medical complications in binge eaters. There are a couple of trials. We see that there's a 3-year follow-up study, and unfortunately the binge eating is not a predictor for weight loss. And when we look at the mixed procedure, this is a 13 to 15-year follow-up, and again binge eaters were more prone to regaining the weight they lost. Suicide is important, suicidality is important. Right after bariatric surgery, there was this 8-year follow-up, and we saw that suicidality rates were higher than expected. And in another trial, the people who attempted suicide after the operation were diagnosed with depression, and the depression lingered post-op. So we have to question whether these people can harm themselves in the post-op period. Of course, there are certain contraindications for surgery. There are 3 important contraindications. There are certain contraindications for surgery. For example, if there's active psychosis, including hospitalization within the last year, or if the person attempted suicide within 5 years, and if they had alcohol abuse within the last 6 months, or substance abuse within the last 6 months, and if they were diagnosed with borderline personality disorder, and if their IQ level is below 50, and if they have severe dementia, then these can be contraindications for surgery. And there are some people whose surgeries can be delayed, and these patients are some psychiatric patients who are suffering from OCD, binge eaters, or severe bipolars, or some mild dementia patients. And binge eaters, their operation also can be delayed. And there are some patients who are accepted for surgery, but these patients need to continue with their psychiatric treatment before and after surgery. These are mild and moderate binge eaters, schizophrenia, depression, anxiety disorder patients. So how are we going to assess the psychiatric evaluations for these patients? One of them is behavioral, cognitive, and emotional, the developmental story, their life styles, and their expectations. When we look at their behaviors, we look at their past experience in losing weight. We have to look at their nutrition or diet behaviors, their physical activity or inactivity, whether they are abusing alcohol and substances, their impulsive and compulsive behaviors, And for cognitive and emotional issues, their cognitive functionality, their level of knowledge about obesity and the surgical procedure, their coping strategies and restrictions, and whether they have a pathology. And we're also looking at their traumas. We're looking at their and of course attachment styles, their relationship with their parents and caretakers. And when we look at their traumas, we also look at harassment issues, and we are also looking at their relationship with their own weight. I mean, whether they were isolated or joked upon by other people. Of course, their life stresses and social support systems, and what they're expecting from this bariatric surgery. If they have some unrealistic expectations, these need to be questioned. We use different instruments while assessing these patients. Of course, we have SCIT, a structured interview system, and we're using questionnaire on eating and weight patterns. We're using eating disorder examination questionnaire. We also have nocturnal eating surveys. We have Yale eating addiction scale. We have the Netherlands eating behavior survey. We have weight and lifestyle inventory. Of course, we're also using SCL90. We're using life quality of life scores. We're using MMPI. So these are some of the scales that we're using in order to assess the patient before and after operation. So, of course, follow-up of these patients are very important. We have to look at the eating disorders or eating problems, because their eating behavior will change considerably in the post-op period. The patient will not be able to eat as much as they want. I mean, physically, there is a restriction because of the surgery. So they have to eat in smaller amounts, they have to chew very well, and they have to stop as soon as they feel full. Because if they eat a little bit more, they start purging again, or they use self-induced vomiting. This is not for losing weight, but this is to lose that discomfort. And these people start to drink high-calorie drinks, or they start grazing. Some people think that after the surgery, the eating disorder gets better. But actually, this is not the case, because these patients will not be able to eat more than is necessary for them. So this is something we have to be careful about. And of course, when they reach a certain level of weight, they are frightened of gaining weight, and they restrict their food intake consciously. And sometimes they can have binge eating from now on. And because of that fright, some people develop anorexia nervosa or bulimia nervosa. Segal et al. Think that they have a diagnosis of eating disorder after surgery. And they're saying that if people are anxious, then they will start to restrict their food intake, they're going to use laxatives, and they will try to lose more weight after surgery. Professor Hoek talked about obesity, whether it's a mental disorder or not. Of course, we know that it's not included in mental disorders, but as a subtype, obesity can be taken into consideration as an eating, related to eating disorders. And after bariatric surgery, some patients, because they stop eating, they can start abusing alcohol, they can start binge shopping, or they can go into, excessive sexual behavior. So this is an addiction transfer, and they can start gambling. So we have to be careful about follow-up of these patients. So we have to make sure that there is not an addiction transfer in these patients. And sometimes, even though they lose weight, you have 2 last minutes. They still think they are very fat or overweight, and despite the fact that they lose weight, they have some sagging skin, and this is going to affect functionality of their lives and quality of life. We talked about a lot of negativities, but bariatric surgery, of course, can bring about some improvements in psychological status of these patients, because the depressive symptoms can improve, and they can have better self-esteem and self-confidence. When you compare pre- and post-op period, you see that you can look at the pre-op stage and post-op stage separately, and you have to analyze these stages separately, because psychoeducation is important, and you have to arrange a treatment program for the patient. And post-op period, because the patient is losing a lot of weight and they are getting better emotionally, then maybe we can recommend them some adjustment or coping strategies. And in the later stages of the post-op surgical period, maybe their social relationships will get better. And if they start gaining the weight that they have lost, then the situation can worsen, and it can create a lot of problems and disappointments and frustrations. If this is the case, maybe we can use psychoeducation, pharmacological interventions. And some of the patients need to be followed up very closely. As a result, we can say that bariatric surgical patients need to be assessed very clearly before the surgery, and a multidisciplinary team need to get involved with the treatment of this patient. Thank you very much.